Attendees are in listen-only mode.
All right, welcome everyone to the February edition of the Trauma Webinar Series. We are lucky today to have Dr. James Gould presenting on blood pressure targets in trauma resuscitation. James is an emergency physician, an assistant professor in the Department of Emergency Medicine at Dalhousie, and he has a fellowship in resuscitation and reanimation from Queen's University. He also works as a trauma team leader and is a consultant physician with our new trauma service. His interests are resuscitation, research, design, and education. If anybody has any questions, I'll just get you to type them into the question box. I know it's confusing. There's a chat box and there's also a question box, but try and hit the question box. I'll read out all the questions at the end for James to answer rather than interrupt him during his presentation. Okay, so without further ado, James, you go for it.
Thanks, Bree. Thanks for the great introduction. Let's rock and roll. You're listening there to Dr. Warren Fieldis, Chief Physician in Halifax, Nova Scotia, with his rendition of Under Pressure. Today's talk is Under Pressure, Blood Pressure Targets in Trauma Resuscitation. And today I'm going to try to provide you with some clarity and frankly reassurance on what is a debated, controversial topic so that tomorrow you can provide care to what are some of the sickest patients that you're ever going to care for. I want to start with a case. This guy's name is Trauma Travis. Trauma Travis has a very serious and unfortunate case. He's a 45-year-old guy, currently unemployed, living in the Halifax area. And as of recently, he's run into some hard times. He's a hard-living guy. Trav recently broke up with his girlfriend. He's lost his job, and he spiraled into a cycle of drugs and alcohol. And most unfortunately, despite multiple previous DUIs, Travis frequently decides to drive while intoxicated. Now, I want you to imagine something. It's 2 a.m. You're in the middle of a busy emergency department shift when a patch comes over the radio. EMS is transferring a 45-year-old. His name's Travis. Travis was the unrestrained driver of an MVC. He's been ejected. He has a GCS of 8, an obvious head injury. His heart rate is 130. His stats are 90% on a non-rebreather. He's got a blood pressure of 77 on 50, and his belly is distended. He has an unstable pelvis, which has been bound, an open tib fib that has been splinted, and they've obtained IV access. They're about 10 minutes from your location. You start to get your team ready, get all the airway equipment into the room, you get some chest tubes out based on the chest trauma. You get blood on the rapid transfuser, and you take a breath. Travis rolls into your trauma bay. The door's open, he rolls in, and he is as advertised. He looks sick as shit. He's got an obvious head injury that has been bandaged by EMS. He's got significant bleeding from a open tib fib wound. You can see his pelvic binders in place. The nurses put him up onto the monitor. His heart rate now is 140. His blood pressure is 70. Saturations are now 85% despite a non-rebreather, and his GCS has dropped to 6. Someone from across the room asks, what do you want for intubation drugs? And a nurse asks you if you want to start giving the blood products. And for the third time, you've heard someone read out the pressure of 70 on 40. What do you do? We're going to try to answer all these questions today. There's a ton running through your head at this point. Is it the right thing to intubate this person? How much blood am I going to give them? What kind of blood am I going to give them? And most importantly, and the basis of this talk is, to what endpoint? What is my mean arterial pressure? Now, to answer these questions, first, you need to have an idea of what we're actually dealing with here. What we're talking about is trauma resuscitation and hypotension. Ultimately, what we're really talking about is diagnosing and managing traumatic shock. Now, people don't typically present with a sticker on their chest saying that they're in shock. And I don't want to confuse things here by starting this talk posing a question to you, but the question is, what does that mean? The rest of this talk, we're going to talk about blood pressure parameters, what we're trying to meet as a surrogate of organ perfusion, but by definition, shock is a state of inadequate oxygen delivery to tissues, and that goes beyond just what the blood pressure is. Determination of traumatic shock, and more importantly, assessment and resolution and success and management of that shock is probably more than just a blood pressure alone. It's the clinical assessment of end organ perfusion. So what are their kidneys doing? Are they mentating? Some of the biochemical parameters of good perfusion and oxygenation of tissues. But you know what? Those things are really difficult to determine in the first 10 minutes of a patient arriving to the ED. So it's something tangible. We're going to discuss what the blood pressure should be. To elaborate a little bit further on the point, I think it's really important to address the concept of compensated shock. If we're gonna rely on the clinical parameters of shock in the first 10 minutes of resuscitation, we need to account for those patients whose physiology has resulted in them being concealed from us. That's compensated shock. Imagine this young patient, trauma Travis. He's gonna come in bleeding with a robust catecholamine response and vasoconstriction. And what's going to happen is his heart rate's going to go up and his pressure is going to relatively normalize. We'll talk about the physiology about that. In order to detect those people so that we can adequately care for them, we can use something called a shock index, which is your heart rate divided by your systolic blood pressure. Or in other words, your heart rate being greater than your systolic blood pressure, or a shock index greater than 1, predictably and reliably identifies patients with active bleeding who are in traumatic hemorrhage, as well as those who need massive transfusion and requirements and, quite frankly, mortality. All right, so what causes traumatic shock? So we can frame why a patient presenting to us might be hypotensive. There's lots of reasons why they might be hypotensive, and really in the resuscitation room, there's a finite number of things that we can actually do for these patients to help try to fix those. By and large, the majority of patients with traumatic shock are going to have hemorrhagic shock or bleeding. That's the most common cause, 40% of death after trauma. Now, you have to remember there's other causes like obstructive shock from tension pneumos or cardiac tamponade or distributive shock from spinal cord injury, or even more rarely, blunt cardiac injury resulting in cardiogenic shock. But it is important to remember those etiologies because those need something different than just blood in order to obtain the hemodynamic goals that we're going to set out in this talk. You know, it's things like a finger thoracostomy for that tension pneumothorax, or needle decompression, or placement of a chest tube. It's things like actual tamponade resolution in the OR or at the bedside from resuscitative thoracotomy when you see those patients at the extreme of their hypotension. In terms of hemorrhagic source of shock, so hemorrhagic shock in these patients, the question that you have to ask is, where are these patients bleeding? And the way that I want you guys to remember this is the floor and 4 places more. The floor meaning external bleeding. Patients can bleed from their scalp, they can bleed from their arms, legs, external wounds, and we need to make sure that we manage that. On the 4 places more are the long bones, the belly, the pelvis, and the chest. And of course, there's temporizing measures for each of these. The pelvis gets a binder, the long bones get a splint, and everything else gets blood products and definitive source control. I want to talk a little bit about the actual physiology of hemorrhagic shock and trauma. For those of you who love the pathophysiology of disease, pay attention. These next few slides are going to be for you. The first phase in a bleeding patient is called the sympathoexcitatory phase. Essentially what happens is when there is blood loss, that blood loss stimulates the hypothalamus to, through a whole bunch of magic and witchcraft, release a bunch of endogenous catecholamines, angiotensin, vasopressin, to try to increase the systemic vascular resistance and heart rate. And what that'll do is it will compensate for that decreased cardiac output from volume loss, resulting in a relatively stable mean arterial pressure for some period of time, unless that process is overwhelmed. The second phase in a bleeding patient is the sympathoinhibitory phase, and this seems counterproductive, and it kind of is. It's essentially increased vagal activity that results in a relative decrease in your blood pressure and heart rate and a relative vasodilation in comparison to what a patient actually needs. Finally, shock-induced endotheliopathy is an important concept in a bleeding patient. The lining of our blood vessels is blood cells. They're endothelial cells. And like any other cell, it's susceptible to shock. So in a patient who presents with any form of shock, including hemorrhagic shock, these cells, either through direct ischemia or the inflammatory cascade that's happening, these endothelial cells can become dysfunctional. And why does that matter? Well, these cells are what contribute to good coagulation at the level of the blood vessel, but also to the appropriate vasomotor tone, so the actual vasoconstriction that these patients need. Thus, there's some amount of temporal nature about the physiology of a bleeding patient. The take home is our bodies are pretty good at initially responding to this. We're basically built to have our arms bitten off by tigers. The bleeding results in an increase in vasoconstriction to try to increase the preload and increase the blood pressure and heart rate. But eventually, without intervention, we start to lose those favorable responses, and there's some amount of vasodilation. And that matters. Stay tuned towards the end of this talk. Along those physiologic lines, one big take-home point, and this is a really big clinical pearl at the bedside in the trauma bay, is that what we really want to know from a blood pressure perspective was there any BP low at any point? That's transient hypotension. So imagine that this person that initially bleeds and has a low blood pressure compensates and then increases their blood pressure so they present to you with normal vital signs in the trauma bay. The important point to that is what I want to know from EMS when a patient arrives isn't necessarily what's the current blood pressure. I want to know that, but I also want to know, was there ever a low blood pressure in the field? A systolic pressure less than 105 at any point increases your chance of needing intervention by 12-fold. All right, so let's talk about the management of hemorrhagic shock. Now, we know what's happening. How do we actually manage it? In emergency medicine and frankly in resuscitation and trauma, we're very familiar with this idea of the ABCs, airway, breathing, circulation. And this framework assumes a priority list, and if interpreted incorrectly, this framework can be detrimental for patients. It is rare that a patient needs an airway now and first, but rather soon or eventually. And if we intubate a patient too early, meaning manage the airway definitively too early, take trauma Travis, for example, if you were to jump in and intubate him hypoxic and hypotensive, then that patient would deteriorate. It would kill him. The laryngoscope is a double-edged sword. There's lots of reasons why Travis might need to be intubated, but he needs to be intubated eventually for airway protection, predicted course. Again, if you take that hypotensive patient and intubate them first, they will decompensate. And why is that? Well, the RSI meds that we give reduce the vascular tone and cardiac function, and the positive pressure increases the RV afterload and decreases the preload to the heart. The negative pressure breathing that Travis is currently doing in the context of his tension pneumothorax and hypovolemia might be the only thing that's maintaining his cardiac preload. And once you take that away, game over. The concept of resuscitation resequence is a really important one. The group from Toronto has sort of coined this and published it, meaning that we need to rethink how we manage the resuscitation of trauma patients. We need to think about the life threats first. So is that like massive external hemorrhage that needs a tourniquet or pressure, or immediate airway compromise that needs, say, a jaw thrust and supplemental oxygen? But they don't need an immediate definitive airway. Those patients then need to be reassessed for all of the targeted interventions that they need to treat their traumatic shock etiology. In other words, the patient needs to be resuscitated before they're intubated. So let's talk about what does it mean to resuscitate a patient in hemorrhagic shock. Well, first, the severely bleeding patient in shock needs blood, ideally some form of massive hemorrhage protocol. And that's easy to say and sometimes harder to provide. I'm very conscious that I'm working in the luxury of having as much blood as I want to give to these patients, and that's just simply not the environment that our pre-hospital colleagues work in. It's not the environment that some of our rural colleagues work in. And so I can only describe what the goal should be. And those that are unable to provide this, conceptualizing the need to move towards that goal if it's a different institution. In terms of how we give patients that blood back, obviously patients bleed whole blood. And as it currently stands, we don't give patients back whole blood, at least not yet. Essentially, our goal should be to balance out that delivery of all of those component parts. So packed red blood cells have the oxygen, the plasma has the clotting factors for hemostasis, and we need to give that back in a 1:1:1 ratio. So what does that mean? 4 units of packed cells, 4 units of plasma or a liter, and a bag of apheresis platelets. Platelets is that last one. In terms of who needs a massive hemorrhage protocol, meaning that not all patients are going to need a massive amount of blood in order to resuscitate their hemorrhagic shock. It may be that the bleeding source has resolved or controlled, and you're giving a certain amount of blood back and they stabilize and all is great. So in order to identify those people that do need a massive hemorrhage protocol, there are a whole bunch of different scores that you can use. You don't need to remember those. You just need to remember this. Think 3ABC. This is again from the group from Toronto that say if the patient is still unstable after 3 units of blood, then A, B, C. Activate massive hemorrhage protocol. Balance 1:1:1 calcium and concentrate being fibrinogen. And that is how you can remember what to do about those patients that need massive hemorrhage protocol. In terms of the C, I really want to focus a little bit on the importance of calcium in these patients because it matters in terms of their hemostasis and optimizing the mean arterial pressure in these patients. We can all remember the lethal triad of trauma resuscitation. Remember that coagulopathy, hypothermia, and acidosis? What we really should be thinking about is the lethal diamond. Patients bleed, they get cold and acidotic as a result, they lose the factors, and the enzymatic changes result in significantly more coagulopathy, more bleeding, and everything sort of spirals and gets worse. And we used to make that worse by giving patients cold saline and dressing them in a cold resus room, but that obviously has gone by the wayside. We warm products, we warm the room, we give them TXA, we do all the things to target that lethal triad. And the important part about the C and 3ABC is that you need to add calcium to that mix. Calcium is a huge integral part about hemostatic processes in the clotting cascade. It's actually also an integral part in vascular tone and myocardial contractility. So those patients that are trying to compensate for that shock, what they need is enough calcium to actually undergo all those processes. And we deplete the calcium, right? Like they bleed out their calcium, they use it in metabolic processes. And iatrogenically, as we give blood products, the citrate that's in that blood product binds up all of that calcium. So we need to give it back. In severely bleeding patients, whether or not that's a trauma or quite frankly, any severe hemorrhagic shock, I give those patients 3 grams of calcium gluconate up front through a peripheral IV. If they by chance had a central line, you could give them an amp of calcium chloride. And I repeat that for every 4 units of packed cells. So really the balance of 1:1:1 is really a 4th one, and that's giving calcium. I've never anecdotally seen a patient who has presented with traumatic hemorrhagic shock or hemorrhagic shock of any other nature that didn't have a relatively low normal, or frankly, low calcium level. So empirically giving this to these patients, I can't imagine would do as much harm as not giving it to a bleeding patient. All right. Let's go back to Travis. So your primary survey and vital signs are all unchanged from the report. You have blood products on the rapid infuser. They're being administered. TXA and calcium have both been given. His pelvis is already bound. His long bone is already splinted. And given the right-sided injuries to his chest and hypoxemia, a finger thoracostomy and chest tube has been inserted. A bedside ultrasound is done as an adjunct to your primary, and here's what you see. So you look at the right upper quadrant, and lo and behold, there's a whole bunch of fluid around that liver tip. You continue with the resuscitation as planned and wonder, what is the goal blood pressure here? What am I actually trying to accomplish? Which brings us to the meat of this talk. What is the target blood pressure in this patient population? First of all, in order to decide what the goal blood pressure is, you're first going to have to decide which parameter are you going to follow. Is it going to be the systolic blood pressure, or is it going to be the mean arterial pressure? Because at some point you need to look up at the monitor and pick one of them. All of the evidence and guidelines we're going to talk about vary in the way that they use these. Some use MAP, some use systolic blood pressure, some give both. Personally, I'm a mean arterial pressure guy. I'm going to advocate for the use of mean arterial pressure. I'm not saying I'm right, and I'm not saying that I'm not willing to be convinced otherwise, but I'll tell you what my excuse is. This is the number one reason why. First of all, blood flow to organs is directly proportional to the pressure gradient and inversely proportional to the resistance. So what does that all mean? The pressure gradient, or the perfusion pressure of the organ, is the difference between the arterial and venous pressures on either side of that organ. What it experiences is the difference between those. Arterial pressure is so much higher than venous pressure throughout the cardiac cycle, which means that the organ will perfuse throughout that cardiac cycle. Thus, the mean arterial pressure, the average pressure, is the best indicator of the inflow to that organ. Essentially, the pressure the organ sees is the MAP minus whatever the back pressure is on the other side of the organ. And in most cases, this is going to be the CVP. The second reason why I would choose the mean arterial pressure over systolic pressure is that automated BP cuffs, or non-invasive blood pressure machines, calculate the MAP, not the systolic blood pressure, making the systolic blood pressure the least reliable measure on the non-invasive blood pressure cuff. In general, this isn't across the board, but pretty well everyone are going to be managed in the resuscitation room or the trauma bay in the first 10 minutes using non-invasive blood pressure cuffs. Over time, they may have an outline. That's a completely different scenario. But initially, and quite frankly, for the most part, through the entire resuscitation, this is what we're going to be using. The way that they work is that they inflate, above the systolic pressure, and as they deflate, they sort of look at these oscillations in pressure, and the reported number is the mean arterial pressure, which is going to be the maximal oscillations. Through a whole bunch of math and science, it then pumps out a calculated systolic blood pressure, which is the reason why it's the least accurate measure on this machine. In terms of that specific question of what should we be using to decide the mean arterial pressure, is it the cuff or is it an outline? And again, just to reiterate, logistically, this is pretty clear to me. Patients do not arrive to the trauma bay with arterial lines for the most part. And quite frankly, otherwise, at least in the initial resuscitation, we shouldn't be taking the time or space around the patient to be doing this. There's probably a role in a certain context, a robust trauma team with lots of people that have the ability to do this in a way that's not going to interfere with the other interventions in the context of a prolonged resuscitation. Or alternatively, when the dust settles and we're trying to monitor for head injury or spinal cord injury, there's not great evidence based to say which one is truly evidence-based better. There is some data from the critical care world that looks at cuffs versus A-lines in terms of how reliable a cuff is, given that the A-line is considered the gold standard. This was a study from 2013 that essentially looked at 27,000 pairs of BP cuff and outline measurements in critically ill patients, so patients that are sick and we care about. And what it showed was that the systolic blood pressure, when it was greater than 95, the cuff underestimated by up to 10. When it was less than 60, it overestimated by about 10. I don't care so much about the underestimates, but if you were to overestimate the blood pressure by cuff, that's kind of a bad thing. The interesting thing and the take home for me from this study was that when you looked at the mean arterial pressures between the two, it was accurate and consistent between both, which essentially for me says regardless of what the patient's pressure is, if I'm using a cuff, I can be pretty reliable that the mean arterial pressure is a good estimate of whatever an A-line would give me. So if I'm using MAP, what is the actual target? So we're going to start with the most common cause of traumatic shock, which we've been talking about, which is hemorrhagic shock. What's my target in this bleeding patient? Which brings us to this controversial, at least I'll say controversial topic of permissive hypotension. The current paradigm for trauma resus balances restoring organ perfusion, providing hemostatic resuscitation, and minimizing coagulopathy. In other words, we give patients blood products, we do rapid imaging and damage control surgery, and then there's this idea of permissive hypotension. So what is it? Essentially, you are tolerating a lower blood pressure, and I say that on purpose. You're tolerating, not targeting, a lower blood pressure to lower the hydrostatic pressure in vessels to minimize further blood loss from the bleeding site. Or in other words, once there's a well-established clot at the bleeding site, this strategy aims to avoid popping the clot. And a number of existing guidelines recommend this approach. So, with that said, you would think that this is all well based in the literature. So let's take a look at what literature does exist, or what is the evidence for permissive hypotension. All right, so to look at the evidence for permissive hypotension, we have to go way back to 1994. Jean Chrétien was the prime minister. Whitney Houston's I Will Always Love You was the record of the year, and Bickle et al. Published immediate versus delayed fluid resuscitation for hypotensive patients in penetrating torso injuries, a New England Journal trial. So what did it look like? Essentially, basically what they wanted to know in this trial was, should we delay fluid resuscitation pre-hospital until operative intervention was foreseeable inside the hospital in hypotensive trauma patients who were penetrating torso injuries? They had a lot of patients in the study. There's like 600 adults, blood pressure less than 90. They were randomized to pre-hospital fluid versus delayed. And what they found was that there was a 70 versus 62% survival. So an increase in 8% survivability when delayed fluid resuscitation was used, or a number needed to treat of 13, which is pretty significant. So what does that mean? Those who didn't get the ice cold bag of saline did better, not surprising. This is cited as being the initial study proposing this strategy as being a benefit to patients. Few things that I want to highlight about this study. The first is that the difference in systolic blood pressure between these two groups was fairly minimal. The aggressive fluid group had a blood pressure of 79. The permissive group had a blood pressure of 72 on average. And in hindsight, one of the biggest issues is that really we aren't looking at permissive hypotension versus not with modern trauma resuscitation. We're looking at permissive hypotension versus giving them a bunch of crystalloid or some crystalloid. Cold, factor diluting crystalloid, which we know is not the right thing to do, and is not how we currently resuscitate patients. So as one would expect, the next step would be, over the next 20 years, you'd see a whole bunch of additional randomized controlled trials, which is exactly what happened. In 2002, Dutton et al. Published a randomized trial, 110 patients, blunt and penetrating trauma. They looked at a systolic pressure 70 versus 100, no benefit. Morrison et al. 2011, 90 patients, blunt and penetrating, MAP greater than 50 versus greater than 65, no benefit. Schreiber et al. 2015, blunt and penetrating trauma, 192 patients, blood pressure of greater than 70 versus 110, no difference. And then finally, Carrick et al. 2016, penetrating trauma, MAP of greater than 50 versus a targeted MAP of greater than 65, no benefit. All of these are essentially showing no benefit statistically to doing what they're calling a permissive hypotension strategy. We should make note that really what we're talking about amongst these studies are three different resuscitation strategies. There's restricted resuscitation, where we limit the amount of volume. There's delayed resuscitation, which is restricting the fluid into a hospital. And then there's true hypotensive resuscitation, which is to titrate and control the blood pressure to a less than normal range, which is really what the Dutton and Carrick studies were looking at, not all of them. So what is the natural thing to do when you have a whole bunch of RCTs and you want an answer to a question? Well, you do a meta-analysis. So in 2018, Tran et al. Did this meta-analysis where they took all of these randomized controlled trials that existed, so all 5 of them, and they put them together to try to see whether or not there was a statistical benefit to what they're calling permissive hypotension. They had 1,100 patients. They looked at systolic pressure 70 to 90 or MAP greater than 50 in comparison to what we define as a normal or a relatively normal and resuscitated strategy. So MAP greater than 65 or blood pressure 100 to 110. The pooled odds ratio is what they reported, and they gave a number of 0.7, suggesting a statistically significant benefit. But what I want to draw your attention to is that greater than 50% of the cases that were included in this 1,100 were from the original 1994 trial by Bickle et al. In the same year, another systematic review was published, this time in the European Journal of Emergency Surgery. They looked at all of those same RCTs, but this time what they did is they basically looked at what was the percentage survival outcome or number needed to treat for what they're calling permissive hypotension. What they found was a 7.1% survival benefit, which is a number needed to treat of 14. Again, greater than 50% of these cases were from that 1994 trial, which we know was almost 30 years ago now, and realistically looking at a different resuscitation than patients currently or even during the latter portion of these studies actually received. Interestingly, this particular systematic review not only looked at those 5 RCTs, but they included all comparative trials that existed in the literature. And what they found was one study that was a comparator trial, non-randomized, by Brown et al. In 2013. It was 600 patients cohort where they analyzed those that got permissive hypotension versus those that did not. And what that trial found was higher mortality in the hypotensive group. And when they add on those 600 patients to the mix of analyzing all of the data amongst the other comparator trials, the difference in mortality reduced to 2.7%, which was non-statistically significant for permissive hypotension. Permissive hypotension really has worked its way into all of the current guidelines in some way, shape, or form. The European guidelines, which is cited here, map of 50 to 60 in hemorrhagic shock, systolic pressure of 80 to 90. The European guideline on hemorrhagic shock is endorsed by the Trauma Association of Canada, or TAC. Interestingly, this is a grade 1C recommendation. What does that mean? A strong recommendation with low or very low quality evidence. All right, so what does all of this mean? Quite frankly, we don't have good quality evidence to suggest that pure permissive hypotension in hemorrhagic shock in trauma has any mortality benefit, especially in the era of our current resuscitation techniques with blood, hemostasis, definitive control. This just has not been looked at. What I think that this does tell us is that if the alternative to permissive hypotension is fluid resuscitation with crystalloid, then that's probably bad. And in that setting, permitting the blood pressure to be lower rather than raising it with saline is probably good. The largest trial that has contributed to the majority of the results in these systematic reviews and guidelines is not hypotensive resuscitation, but rather restricted volume resuscitation when that volume is crystalloid. And so I'm not saying that permissive hypotension isn't supported within the guidelines, that you wouldn't be supported to be using it, but rather I question the quality of evidence within those guidelines and systematic reviews and whether or not it actually tells a story of support for permissive hypotension broadly or for a more specific patient population in a more specific context. In other words, the young penetrating trauma who would otherwise be getting volume resuscitation with crystalloid to meet that hemodynamic target. So what about the harms of doing permissive hypotension? One of them that has sort of reared its head recently is the potential for cardiac injury. Just last year in the Journal of Trauma and Emergency Surgery, a retrospective study looked at patients 18 years or older over a 3-year period. And essentially of 343 patients with a MAP less than 65, there was an odds ratio of myocardial injury of 1.2, which is their primary outcome. That myocardial injury was essentially an elevated troponin, and the patient doesn't necessarily care about that. But if you look at the secondary outcomes between hypotension, there was an increase in MACE and in hospital mortality, which obviously the patient does care about. Most of these permissive hypotension trials were conducted in younger patients. The average age in all of these trials was around 30 years old. And this is just not who we see. Like, imagine Trauma Travis is not a 45-year-old, but a 75-year-old. Does that change whether or not this evidence is actually applicable to him? Patients with elderly age and more susceptible brains might need a higher blood pressure to meet their baseline mean arterial pressure and chronic hypertensive needs. Finally, and maybe most importantly, these don't generalize to the people we see most often. These studies rightfully exclude those with confirmed suspected brain injury or severe TBI. These studies are really looking at isolated hemorrhage in the context of penetrating trauma, and that's just frankly not who we see most often, at least in Canada. We see blunt trauma with a high index of multi-system injury and potential for TBI, and this strategy of permissive hypotension is detrimental for those with potential TBI, like Travis. So let's talk about why. TBI is important. We all know that. It has greater than a 20% mortality in the context of severe TBI. This was a study from a Canadian cohort in 2017 looking at admitted trauma patients over a 6-year period. And of those, a half of them had a TBI with no injuries of greater severity. So quite prevalent amongst our population of trauma patients. There's lots of different TBIs. To provide context of what we're actually talking about here, there's obviously the extraaxial bleeding, so the epidural, subdural, subarachnoids. There's the bleeding inside the brain, as well as the sort of injury we can't necessarily see in terms of the diffuse axonal injuries. And these are all diagnoses that are made after diagnostic imaging. At the bedside, what we're trying to determine is the likelihood of a severe TBI based on that patient's presentation, so that we can then decide what the heck we're going to do about the blood pressure right now. In terms of how we quantify that, the Glasgow Coma Scale, which looks at mild, moderate, or severe being 13 to 15, 9 to 12, or less than 9, or 8 equal to 8 or less being severe. And that's the patients that we care most about in terms of MAP targets. All right, so let's first talk a little bit about the physiology of the brain and about what the brain needs for MAP, which is going to help us understand what the MAP target is going to be. The brain is a fixed space, an enclosed, non-expandable case of bone. And in the baseline state, we essentially have some venous blood, some arterial blood, some CSF, and then the brain, pretty important part. If you introduce an additional component, so that blood or increased edema, etc., the brain can compensate, or the head can compensate by changing some of those fluid compartments, but at some point, that compensatory state will no longer remain and the intracranial pressure will rise due to the fixed volume. Now, perfusion of the brain, as we mentioned, is the mean arterial pressure minus the ICP. When the ICP, we assume that as the ICP raises, it gets above the CVP, and so the actual perfusion pressure, or tissue perfusion pressure, is going to be the MAP minus ICP. So as the ICP increases, perfusion goes down. And unfortunately, the ICP raises pretty quick when those compensatory mechanisms are lost, meaning the CPP will drop really quick. The brain's pretty smart. It's able to auto-regulate the amount of blood flow that's coming into the brain by vasodilation and vasoconstriction, so that over a wide spectrum of cerebral perfusion pressures that you see here on the x-axis, the brain is able to regulate how much blood flow it's getting to what it actually needs. Unfortunately, in the context of trauma, this can become dysregulated. So as the MAP goes too low or the ICP goes up too high, then you get a drop in your CPP and ultimately a drop in blood flow. There's only a few things that you can really do in the resus room in this situation to control ICP. You can take this thing here and loosen it up so that the venous blood can drain from the brain a little bit better. You can elevate the head of the bed to 45 degrees to try to reduce that, or increase the venous outflow to reduce the ICP. You can do things like osmotherapy, right? So try to draw some of that fluid out of that space to try to decrease the ICP. But that's really it. There's not a whole lot of things that we can do at the bedside, at least in the initial 10, 15 minutes of this patient's resuscitation, that's actually going to be able to change that number. What we really have a bigger impact on, and what we can control in that first bit of resuscitation, is the mean arterial pressure, which is going to be the thing that contributes to that cerebral perfusion pressure. The MAP is extraordinarily important here. It's been quoted that any episode of hypotension in these patients with severe traumatic brain injury increases their chance of mortality by 150%, one episode. So we know hypotension is bad, and the long-standing recommendations to this point have been for some higher BP target. But what is that target? There's lots of different guidelines. It'll kind of, you could go through and help guide you to say what the ideal pressure would be. The Brain Trauma Foundation guidelines are probably the most robust and the ones that we look to the most in terms of guidelines for this. In 2016, they published the 4th edition of their guidelines for severe traumatic brain injury, which is what you'll see endorsed by associations like ATLS. And here's the numbers that they came out with. So here's the systolic blood pressure target that they recommend. Systolic blood pressure greater than 100 for those 50 to 70 years old, greater than 110 for 15 to 50, or greater than 70, so a little bit of an age jump there. This was basically from a 2012 study by Berry et al., where they did logistic regression analysis for these 3 age groups. So they like broke them all up into the different age groups and said, all right, of all of these trauma patients, and this was at 13 different trauma centers over a 7-year period, they said, like, what was the best blood pressure for these 3 groups that resulted in the best survivability? And these are the cutoffs that they settled on. What about the guidelines? So again, the European guidelines endorsed by TAC recommend a mean arterial pressure target, so not a systolic pressure, but a MAP greater than 80. We already talked about the fact that CPP is MAP minus ICP, and the brain trauma guidelines are fairly clear that a CPP, or perfusion pressure, of 60 to 70 is ideal. We really don't know what the ICP is in these patients standing at the bedside. We don't have an ICP monitor. We're not going to be able to know exactly what the CPP is given a specific MAP. But in general, if we assume that that ICP is somewhere around 20, worst case scenario, then a mean arterial pressure greater than 80 should suffice to provide us with a perfusion pressure greater than 60. One really important thing to mention from a practical perspective, and something that may change how you manage the mean arterial pressure in these patients, is a great deal of these head injured patients, especially those that are MBCs, which is, you know, the patients that we see, they have a high incidence of concurrent traumatic brain injury and spinal cord injury. The guidelines on spinal cord injury are fairly clear that they benefit from a MAP protection of greater than 85. And the incidence of concurrent spinal cord injury with severe TBI is high as 12%. Ultimately, at the end of the day, when it comes to managing TBI, BP is exceptionally important for all the reasons that I mentioned. But in general, we need to avoid secondary injury to the brain. That's our goal. It's just the blood pressure is a piece of the puzzle. We need to avoid hypoxia, hyperthermia, hypercarbia. All of those things tend to worsen the patient's outcome. So in terms of the moment in someone's resuscitation where you have the potential biggest impact that you can have on worsening their mean arterial pressure is probably in airway management. We already talked about how detrimental and dangerous that can be. This is just exacerbated even farther because you have a fragile brain that just needs that mean arterial pressure. So again, you transition them to positive pressure, you give them medications that are going to change their blood pressure, and quite frankly, make them apneic and introduce the risk of hypoxia and hypercapnia. And so during that period of time, to avoid that iatrogenic injury, optimize the patient, resuscitate them, pre-oxygenate them, and use a hemodynamically safe approach, which is ideally with an agent like ketamine to reduce the changes in your blood pressure. All right, let's come back to trauma Travis. He has his chest tube in place. His pelvis has been bound. He's still getting massive hemorrhage protocol and hemostatic resuscitation. And at this point, we're faced with a patient with hemorrhagic shock with presumed TBI. So his GCS is less than 8 and he's got a head injury. So on one hand, we have a body of literature telling us a MAP target for bleeding patients. And on another hand, we have a body of evidence telling us what to do about TBI. And the question is, what the heck do we do with trauma Travis? Which takes priority? In general, what is the biggest life threat? What's agreed upon within all of these guidelines, and the evidence, quite frankly, is that the concept of permissive hypotension and MAP management and bleeding does not apply to those with head injuries. They're all excluded from the majority of these studies, not all of them, but the majority of them. And all of the guidelines are very clear on not applying this broadly to the head injured patient. And the head takes the priority until we can definitively rule out the potential for a head or spinal cord injury. We need to be protectors of the MAP. And in this case, the brain and the higher MAP wins out. All right, we're going to switch gears. It's great to say we need that MAP of 80 to 85. The next question that I have for trauma Travis and for you is, how do we accomplish that goal? Is that just massive hemorrhage protocol and volume and all the hemostatic stuff we talked about? Or is it something in addition? What about pressors? A seemingly blasphemous statement, I'm sure, for some when it comes to managing hemorrhagic shock. And the question is, are pressors a never event in trauma resuscitation? And the answer for me is no. And I'm going to make an argument for why they're useful in all of the scenarios that we've discussed so far. First, does it make physiologic sense? There's the easy one. There's the easy yes, which is the neurogenic shock patient. Recall that, spinal cord injuries have some dysregulated sympathomimetic response resulting in vasodilatory shock. So it's obvious that in those scenarios, once bleeding is ruled out and you've treated the other causes of hypertension, that patient would benefit from receiving pressors. Further to that, in a TBI patient whose volume repleted and resuscitated with blood products or whatever else they need in an isolated head, it also makes sense that vasopressors could artificially create an improved MAP scenario and improve CPP to meet the targets that we already talked about if needed. Not all these patients will obviously need any of that, but if required. The bigger question and the debated one is going to be, what about the patient with hemorrhagic shock? Or what about the one who's still actively bleeding? Again, the dogmatic answer is going to be they need back what they're losing. They need blood. Pressors don't fix the problem. They've lost their preload and cardiac output. Treatment should be aimed at replacing that so that you can replace oxygen delivery. And that's 100% true. It's just not the whole story. And recall at the beginning of this talk, we talked a little bit about the physiology of hemorrhagic shock. Initially, there is that profound sympathomimetic response of vasoconstriction and increased endogenous catecholamines, but eventually the catecholamines deplete. There's counterproductive neuroinhibitory response. There's inflammatory cytokines. There's endothelial shock that leads to loss of vasomotor tone. And quite frankly, over the span of resuscitation, the massive hemorrhage protocol, blood products themselves can lead to systemic inflammation and vasodilation. So vasopressors can act to complement the vasomotor response that we need, as well as replace it as it starts to go away. Furthermore, vasopressors can lead to a slight increase in the patient's cardiac output and preload, improving oxygen delivery. The example would be norepinephrine. Norepinephrine not only alters arterial resistance and increases systemic vascular resistance, but it also acts on the veins, right? It has adrenergic effect on the venous system, specifically the splanchnic system. So if you vasoconstrict that and move and shunt the volume of blood into the venous circulation, systemic circulation, then that will result in an increased preload and increased cardiac output. Finally, again, we need to protect the MAP at all costs. We are protectors of the MAP. Ultimately, the brain, the heart, the organs, they need oxygen delivery, but they also need a perfusion pressure. And in the setting of exsanguination, massive exsanguination, in the short term, the coronaries probably don't care how they get the MAP. They just need the MAP, because otherwise they're going to spiral. The cardiac function is going to decline, and those patients will eventually arrest. So what is the evidence? Am I crazy? What is yet? Obviously, what does the evidence say about this? Give us the evidence. The animal literature, which is not great, but exists, essentially says there's less bleeding, increased survival, and preserved gut microvilli. So there isn't seemingly significant adverse effect in terms of ischemic valve from doing this. But that's rats, not humans. What about the human data? This trial from 2019, the AVERT shock trial, was the first of its kind, a randomized controlled trial that looked at vasopressin in hemorrhagic shock. So vasopressin is an interesting pressor. And not only does it cause vasoconstriction, but it also enhances the sensitivity of the catecholamines that are circulating. It enhances the hemostatic effect of platelet activity. And as we said, it's depleted throughout trauma resuscitation. And so it sort of physiologically makes sense to use this drug. This randomized controlled trial over a 3-year period essentially enrolled patients that got 6 units of blood. So they're pretty sick patients who got either placebo or vasopressin, bolus plus an infusion. When they looked at the total blood products used over 48 hours, this is the primary outcome, there was significantly less blood product use and no difference in adverse events. So seemingly a positive trial, not necessarily a patient-oriented outcome, but a positive outcome. All right. What about the other pressors, specifically those used in the animal literature, more commonly used in the resus room, like norepinephrine? To complicate the picture, lots of previous non-randomized observational type trials have looked at this specific question and have shown sort of hypothesis generating associations between mortality and vasopressor use, which sort of leads us to the old adage of norepinephrine or Levophed being Levophed, leave them dead. Probably the largest and most relevant study that kind of answers this question was actually just published in JAMA in October. It was a retrospective multi-center trial, all blunt trauma, so very relevant to our population, recent, between 2013 and 2018, sick, blood pressure less than 100, evidence of hemorrhage. And what they did is they looked at patients that got norepinephrine and what their associated or predicted average treatment effect was from getting the norepinephrine on their mortality. They had 1,500 patients. About 70% of them got norepinephrine, 25% of them got them in the trauma bay, and there was no increase in mortality. So obviously there's a need from an evidence perspective for higher quality randomized controlled trials, but this is probably the most convincing data of the observational data that exists that says norepi is probably not much of a harm in the blunt trauma patient. I think there's a subgroup of patients that we really need to focus on here in terms of where pressors might be useful, and that's those that get the iatrogenic injury of the intubation that we're going to provide a great deal of these really sick patients. So this goes back to a study in 2017 by the famous Dr. Rob Green, published in the Journal of Trauma and Acute Care Surgery. Essentially what they did is they looked at 477 patients needing to be intubated by our trauma service, and the prevalence of post-intubation hypotension, 36.3%. That is amazing. That is a lot of patients that get hypotensive after our intubations. And the interesting thing about these patients is that in the 30-minute window leading up to the intubation, there was no difference in the resuscitation, no difference in the meds that they were given. And in fact, if you followed those groups out, the ones that got post-intubation hypotension had a higher risk of in-hospital mortality. The summary for me from that, and the idea that I know that post-intubation hypotension leads to badness, especially in the traumatic brain injury population, from a theoretical perspective, I could make an argument that any patient I'm intubating in traumatic shock, I would have inline norepinephrine running during the intubation to offset the potential of these hypotensive episodes. I'm not saying I have evidence to support that that works, but from a theoretical perspective, it makes sense. I'd even consider increasing my MAP slightly higher than what I want it to be, knowing that there's going to be some hypotensive episodes after the intubation. Finally, vasopressors are in fact recommended in hemorrhagic shock in some of the guidelines. The European guidelines specifically, the only one that sort of recommends vasopressors, and it is endorsed by the Trauma Association of Canada. So in summary, for all these reasons, I'm inclined physiologically to manage hemorrhagic shock with a combination of massive hemorrhage protocol and sometimes careful use of vasopressors during the general resuscitation phase, but definitely during the peri-intubation phase. I wouldn't rely on vasopressors, especially early. The tagline for me is it's not a good substitute, it's a good addition. It supplements what must be a primary focus on restoration of blood volume in a balanced and hemostatic way. All right. We've come to the end of the talk. I want to end this practically for you guys and sum it all up. So what can you do tomorrow when you need to treat hypotension in the sickest trauma patients that you're going to see? How to play in the trauma bay. If the patient is presenting to me with an isolated traumatic brain injury or declare themselves as such, my mean arterial pressure target is going to be somewhere between 80 and 85, so greater than 80, leaning towards the higher end of 85 if I suspect a high index of suspicion for spinal cord injury, until I've confirmed otherwise. And how am I going to accomplish that? Well, first I'm going to resolve any sources of hypotension. And if they're volume replete, then obviously I'm going to be targeting that MAP with a MAP push with vasopressors. Isolated hemorrhagic shock, my default is going to be targeting a MAP greater than 65. I'm going to accomplish that with massive hemorrhage protocol, hemostatic resuscitation, definitive hemorrhage control, and I'm happy to use vasopressors as an add-on to protect that MAP goal, and as an add-on to the important stuff that we're going to do, especially the peri-intubation phase. I have an asterisk here, a really important asterisk. I would never criticize, and quite frankly, the guidelines would support tolerating a MAP greater than 50 as opposed to greater than 65. And I, in fact, would do that in some patients. I would do it in what I read to be the evidence for doing that. In young patients who are mentating, preferably with a penetrating source of injury, whose alternative is going to be to tolerating a MAP of 50 would be giving saline to get them any higher. In terms of what do I do when there's both? So hemorrhagic shock in the context of a TBI, the brain takes a priority. I'm going to target a MAP of 80 to 85, greater than 80 to 85, and I'm going to do that as I discussed with resolving the cause of any hypotension and then pushing the MAP with pressors to achieve my goal. The disclaimer is, listen, look, this is my opinion. This is my interpretation and read of the evidence I've chosen to read. And it doesn't mean I'm right, and it doesn't mean that this isn't going to change over time, because quite frankly, I think the answer to some of these questions are not yet answered. It's trying to provide some clarity to a question that has no clear answer. And perhaps that's just the art of resuscitation. Come to the end of our talk. This is Trauma Travis. He's been resuscitated. He's had master hemorrhage protocol, vasopressors to target a MAP greater than 80. He's been intubated, hemodynamically neutral intubation strategy, after which he's stable and appropriate for transfer to CT to characterize the injuries. I'm James Gould, and that's Under Pressure, Blood Pressure Targets, and Trauma Resuscitation. Happy to take any questions. Thanks, guys. One thing that I want to just leave on the screen while taking any questions from Brady is QR code. This is I'm going to leave this up on the screen while I take questions. If you point your phone on it, it'll bring you to a website that we made called the Resus course. If you like this talk or want more talks like it, or podcasts, video series, we have a lot of free open access stuff on the website. The Resus course is a course as well that's being developed to be offered sort of more broadly. Yeah, and you can, if you have any questions or you want to reach out, I'm also on Twitter at the Resus course. Thanks, guys.
Hi, James. There's one question, it looks like.
Okay. Can't hear you, Bree.
Everyone saved their questions to the end, so we just have a couple of them. Are there guidelines for pediatric TBI under 15 years old?
Oh my gosh, great question. The Brain Trauma Association does have pediatric guidelines. I'd direct you towards braintrauma.org, and under that they have pediatric guidelines for severe traumatic brain injury. In terms of permissive hypotension, I think, and I can't quote the evidence, but I think that in general, the statement would be that permissive hypotension doesn't apply to that patient population. But I'm not a pediatric emergency physician or trauma doc for that matter. I don't care for any sick kids other than my own. So I can't give you a great evidence-based answer for that. It's a great question.
Another question, blood products have an enormous amount of potassium. Does this translate to our approach?
Read that again, Bree.
Blood products have an enormous amount of potassium. Does this translate to our approach, I guess, like towards hyperkalemia?
Oh, good question. I think I would imagine that the amount of potassium is probably, I can't cite evidence on this, but I imagine in terms of the overall resuscitation probably doesn't lend itself to negative outcomes in terms of the blood products. I'd imagine the amount of sort of acidosis from significant hemorrhage and shock probably leads to more shift in hyperkalemia than you'd see from blood product administration. Either way, at the end of the day, these are patients that I'm fairly closely monitoring with, if they stay in the resuscitation room, that is, with VBGs. And so, you're probably going to be aware of any clinically relevant hyperkalemia.
They're also wondering if you have a preferred crystalloid during resuscitation, i.e. saline versus lactated ringers.
I have none because I don't want to give it necessarily. I would say that if I was going to give it, then a balanced crystalloid ringers lactate, and that's not, the evidence obviously swings back and forth. There's this perpetual pendulum of isotonic sort of saline versus balanced crystalloid debate in resuscitation, and it's gone both ways over the years. I've seen it go back and forth twice now. So I can't say that for sure that I know of definitive evidence one way or the other. If I had to choose and was going to give crystalloid to a patient, I'd give a balanced crystalloid, so ringers lactate.
Another question, although there might not be rock solid evidence, would you be in favor of EHS providing pre-hospital IV calcium to load up a patient before arriving at the hospital, reducing the necessary interventions in the actual trauma room?
I think that would be a really good thing to study. And I think it wouldn't be a difficult thing to study, especially in a trauma system that had VBG available. All these patients get blood work when they arrive. And so the initial thing is probably, confirming what I've seen anecdotally, which is that the majority of these patients at baseline have a low calcium level. And like I said, for the most part, I will just give that empirically up front. Don't think too much about it. I wouldn't worry too much about it. So to translate that into the pre-hospital setting would make sense. I think you'd want to see some evidence first to suggest that the majority of these patients are relatively hypocalcemic before they get to the emergency department. Whether or not that'll translate into better outcomes for patients is another question. You know, we see it all the time, right? This like, yes, doing this particular thing is good, but does that translate into goodness when you do it in the pre-hospital setting? I think is the bigger question. In a prolonged resuscitation pre-hospital or prolonged transport of patients, or like the timing of, you know, them receiving larger volume resuscitation, whether or not it's at another site getting blood and then being transferred, it's certainly pre-hospital calcium in that situation makes sense to me.
Another question kind of on a similar pathway. Thoughts on permissive hypotension in the pre-hospital setting now that blood components are available in this setting?
Yeah, great question. I think that this is kind of one of those things where we're kind of in an evidence-free zone because all of that evidence from a pre-hospital perspective involves giving crystalloid. I think that in a world pre-hospital, we're always going to be faced with a limit in the amount of crystalloid that we're going to, or sorry, the amount of blood products that we're going to have. So I think the answer truly is if they're bleeding, they need the blood, but at some point there's not going to be enough of it. And then you have to decide what you're going to do next. And I think in that setting, if the alternative, once the blood's gone, if the answer next is whether or not I'm going to give saline, I think that's probably, so long as there's not any contraindication, that's probably the patient that permissive hypotension based on the literature would still support doing it.
And then one last question I can see. Can you comment on bolus versus infusion of vasopressors? Is titration better?
Yeah, great question. I guess I can comment on the peri-intubation phase. You know, we over the years have done a lot of push dose pressors in the context of hypotension from intubation. In my mind, that's a bit more of a response rather than a prophylactic act. And so if we predictably know that patients will become hypotensive after they're intubated, in my mind, it makes more sense to have an infusion running that is going to protect them from that rather than responding to it with push dose. The alternative, and in some settings, people do just integrate the push dose within the medications that they're giving. I think that would sort of fall along the same lines as the prophylactic infusion. I would support both of those concepts greater than I would the idea of a reactive push dose to low pressures. In terms of just general resuscitation over time, I can't say that I have great evidence to say what's better, doing an infusion of norepinephrine versus doing bolus doses of epi or norepi or phenylephrine. What I would say is that infusions to me always seem like a more controlled situation. So in a prolonged resuscitation, I'd much rather just have the ability to go up or down on the infusion rather than having bolus and chase.
All right, James, that looks like all the questions. Thank you so much. That presentation was wonderful.
Thank you so much. Thank you everyone for listening. Have a great day.
Thanks.